Thank you so much, Angelica. If we can go ahead to the next slide. So I thought I'd better tackle embedded research in terms of a workforce in VA to begin with. And it sounds like it represents many of you that are on the call today. Our embedded research workforce is comprised of clinician researchers and social scientists. And the difference in embeddedness is really that these are folks who are employed by the healthcare system. We have academic appointments, but we become knowledgeable of the needs of veterans as our patients and of the delivery system. And our clinicians get protected time. So they're hired as clinicians and they can carve off protected time for research as they get funded as principal investigators, as they lead projects or other activities, while the social scientists, the non-clinician PhDs, get salary from research grants and our operations funding directly. As I mentioned, most of us have academic appointments in our affiliated universities and schools. Now, the other part of this workforce are clinical leaders, innovators, and other implementers, including systems redesign folks, systems engineering, improvement staff, and sometimes they're trained in research, sometimes they act as our research partners, but they're a critical part of the puzzle pieces in what we do. And we get a mix of research and operations funding that's available. So that may be national, regional, and local operations funding for evaluation or quality improvement. And then we have an intramural health services research program, as well as the Quality Enhancement Research Initiative, or QUERY, that uses operations dollars to do implementation and to do randomized program evaluation. Next one. So I wanted to give you a couple of examples and what we learned from them to just dive in, and I'm only going to talk for 10 minutes and then we're going to open it up for your Q&A. So this is an older example where one of our clinical scholars found that over 40% of our positive FOBTs had not been followed up by colonoscopy within the recommended time period. And as a university-based clinical scholar doing VA work, the university generated a press release emphasizing that quality gap, which was quite substantial. And to be appropriate, we submitted that press release to the National VA leadership ahead of the print of the manuscript that was reporting these results. And I can tell you quite literally, I had a flurry of calls all the way up from 11 or 12 at night from our VA network director asking about what was going on with this study. There were calls for changing the press release. Can't you just say that 60% were followed up and emphasize that? We said no. And they just assumed there was going to be terribly bad press around this issue. I have to say that ultimately the journal in which this was published was not a top tier journal. There was virtually no press at the time. But I have to say the activity that happened around this, the VA had done so much work anticipating reactions to the findings that they ended up designing ultimately and pursuing a national colorectal cancer screening and follow-up improvement initiative that was wildly successful and helped the VA system nationally yield the best screening and follow-up rates in the country, all because of one probably unread manuscript at the end. Next. So what did we take away from this? Well, it was a little spooky at the time and I didn't like getting woken up, but the research was perceived as potential bad news and it engaged system leaders in ways, to be honest, good news doesn't. I routinely send out good news email volleys to different leaders at different levels because they're so used to hearing bad news that sometimes they're just like, oh, thank you. I like research because now I know that something or other wasn't a problem. Or, oh, someone got an award. Isn't that nice? Because again, everything on their plates is just about always bad news. So what happened here is the bad news, the perceived bad news, rapidly increased awareness of the problem in a way my own manuscripts that they might or might not read would never do. And this problem was poor follow-up. It catalyzed a high level of demand for action given the risks of inaction. It engaged other researchers to assess the quality of bad news. Literally, I was asked multiple times at multiple levels in the organization on whether or not this quality scholar's work was any good. Do we have to believe it? Do we have to listen to it? And that created this new research operations collaborative to design the system fixes in partnerships that would allow for strong evidence and strong action. They incentivized the use of operations funds at a level we could never expect in research, to spread a systems remedy and to collect data that was then usable for research afterwards. And the partnership that ensued created just a remarkably fast data access opportunity, faster engagement of key players at the national, regional, and local levels, and resulted in increased research funding for years to come. So I, in my own career, look for win-wins. This was like a win-win-win-win. It was really quite remarkable. And the academic rigor at the other end of this was what enabled researchers to push back with evidence when people started questioning what was learned. Next one. Now, my other example is much more recent. From a baseline survey from one of my cluster randomized trials of an evidence-based quality improvement approach to gender tailoring VA's medical home model to women veterans' needs. I had been hearing for some time an anecdote from women veterans indicating that they came to the VA once and didn't come back, or that they had been harassed. And there was no data on this really at the time. And I thought, this is a survey about primary care exposures and experience. And I thought, let's put in a novel survey item, open-ended no less, in this survey. And what we found was that 25% reported having been harassed when they came to the VA to see their doctor. And when we analyzed those data further, we found that that was, bad enough on its own, but was in fact associated with delayed and missed care, which is unacceptable. All of it was unacceptable. We were admittedly pretty concerned about reporting this. This was right before the Me Too movement, so we were in the mix there. This particular set of studies was kind of a program project, if you will, and we were partnered with the head of VA Women's Health Services for the country. So we were in a position where we were having monthly calls with this leader. She was very adept at understanding and engaging in research evidence. And we reported the results to her internally as soon as possible. As soon as we were like, did anyone recode something wrong? It was pre-publication, and we really pushed hard because we knew we were taking this to the head of the program. And it was well before publication. So the partner immediately recognized how serious this was and funded us to do evaluation work. We did a literature review on what else was known about what works to reduce stranger harassment. We did focus groups of male and female veterans separately to understand both the more detail about the experiences, as well as why do people do this, what's going on for folks, key stakeholder interviews, police, disruptive behavior communities, facility directors, and all led to an expert panel. And that happened in 1 year. Okay, that's the operations timeline. By the time the paper was published, we were able to include a description in the discussion section about how the system responded, which made it then picked up not only by the press, it was also editor's choice because of that story that was told from soup to nuts. And it was also picked up by congressional staff. That definitely helped increase tensions. And more research has been funded, more evaluation work has been funded ever since, and there have been a large number of briefings. And in fact, there's now legislation that has been passed to mandate the VA to act on these harassment activities. That story is even more complicated than I can present here, but it's been a fascinating case example of how research can be transformative. Next one. So our lessons is, again, better for worse. Bad news created a very strong multi-level reaction. The operations funding that was offered to us instead of trying to get somebody else to check our work, they said, okay, we believe the data. We had a long-standing relationship with this operations partner, and we were able to basically then create a rapid and actionable evidence base from the operations funding in a way that for research funding might have taken us 2 or 3 more years. That yielded pilot data that we then could cite in our research proposals, which accelerated the funding of research as well. And the partner was seen as proactive. And in fact, for us, what's gold is she promised to implement the results of our research. When you have a letter of support in your grant that says, I am ready for this research, I am engaged in this, and we will act on policy based on it, it's gold. And of course, that means you have to do high quality work as well. So they're counting on the rigor of your evidence. So that's that partnership, the strength of it, as well as the tension. This also reminded us the importance of being able to translate our research findings for non-research audiences. So while our peer-reviewed publication demonstrated the rigor and the necessary credibility of the findings, we then developed lay summaries that helped our partners and others get the research value and be able to act on those findings. And finally, the partnered work created the foundation again for more research dollars, and regular partner calls also help us identify new opportunities. So we now have researchers on these national work groups, and we have been presenting the research to chiefs of staff across the country and been briefing folks on the Hill on it. So it's very engaging from beginning to end. Next slide. So I wanted to focus, those are just two of many examples over my tenure and that of others, no doubt, in the VA embedded research workforce. So there's just some big picture lessons and practical solutions I wanted to mention before we open it up. One thing is not all partners are created equal. I have been told over time that, I've got the best partners. My argument would be lucky me, yes, on that one, but we have to help all of our operational partners be better consumers of what we do. And there are strategies for doing that, including not speaking in p-values and beta coefficients. We're not trained well enough in that area. But because partners are not all created equal, it's really important to engage multiple levels and multiple partners. At one point, I know for the VA Health Services Research Centers, there had been a push to have each center identify a single partner. And I had a very strong reaction to that because I've seen, this issue of no one person can be all the kinds of things you might need them to be in a partner. So one other thing we often do is to use national and network level leaders above at the highest levels that drive where the resources go in the VA, and frontline providers and staff below who are experiencing what's happening in care and what's going right and what's going wrong to make the case for adopting research evidence to the medical center leadership in the middle. And that kind of pincer movement has been very successful. Often because the people in the middle are just struggling with so many things to have to set priorities with. I also say it's critical to strengthen your messaging in terms of that each level understands and values. And that's not easy. Again, we're not really trained in that along the way. The other reality is partners may not trust researchers. We do have different goals and objectives, and we don't always understand what their requirements and demands are. And so we typically engage trusted associates. And despite the many years you've all spent in, being able to, though I say usually it takes 10 years to figure out how to write for scientific literature, which is 10 years to figure out how not to communicate very well to the rest of the world. Getting a testimonial from colleagues means so much more than any of our statistics. As sad as that may be, it's just truth. And the faster you get to that, the better. It also takes time to build the relationships necessary for having these embedded research and operations partnerships. And you have to understand the context of your partners so that not only are you communicating your science more effectively, but you put it in a context that matters to folks. So we often do things like share our past work. We demonstrate that what we do is useful. One time, our national organizational surveys, I've gotten upwards of 90% response rates from busy primary care directors. It's been harder. It's been nearly impossible during COVID. It's been harder during an access crisis the VA had. But all I did was send them a list of all the papers and the reports that we had done from our prior organizational work, so people could see that, in fact, something useful came from it, and that they then could order any of these products themselves, and they did. And so, those kinds of things can be helpful. And just sharing results with those from whom you've collected data, so they understand, again, that there's something that happened with the time they spent investing in you. And that's true of our operational partners and providers and staff as well. And then there's just the simple thing that we sometimes forget, and that's rewarding and recognizing the work of our partners and researchers. I write a lot of dossier letters for clinical leaders. I write a lot, I do simple certificates, just thanking leaders opening up their entrees. And a lot of those end up on people's walls because they are under-recognized and overworked. And it doesn't take that much more for us to remedy that. Next one. I would say also work to create a responsive culture enabling flexibility and nimbleness. I can't tell you how annoying it is to an operations leader to have us spout, our slow timelines and how many papers we have to publish to be successful. That may be our problem, it's not theirs. So to the extent that you can build in a rapid response capability, I would say do so. Even considering a strategy for an applied health services research unit. We've done that here locally in what's called the Evaluation Decision Support Unit, and it is parts of different health services researchers at my center who are funded now by the medical center, not by research at all, and they're focusing their qualitative and quantitative skills and just frankly their critical thinking and evaluation skills on specific problems that the organization's having. First year out of the gate on a proof of concept, Joint Commission came in and said, oh my God, that's a best practice. And now we're working on an MOU for 5 years of funding. So it's, demonstrating value, and our researchers love it because they went into this to make a difference. This is make a difference every day kind of stuff. And they can publish from it as well. I'd also say continue to develop techniques to speed feedback of results in easy to understand formats. Lay language, sound bites, data visualization are key here, and be clear on the deliverables with your partners and deliver on them. I shouldn't have to say that, but it's very important. So just be responsible for how partners view the value of our future research partnerships. And then finally, I'd say from my experience in the system, the embedded research we're able to do in partnership with providers and managers and leaders is central to the health system's achievement of learning healthcare system principles. The value of what we do as health services researchers is quite extraordinary to the system if we can communicate it in a way that's useful, if we can in fact demonstrate impacts on what they do. And to be honest, in return, the system knowledge and the engagement we do enables major research impacts. So it's been an incredible opportunity in the VA that I look forward to continuing. And I think that's it for my slides.
Great. Thank you so much, Becky. I'm going to stop sharing this presentation so everyone can see you a little bit closer up, and we can have that little bit more personal connection that we're trying to achieve here in bringing this information to you. So what I'd like to do at this point is encourage everybody, if you have questions, to go ahead and pop them right into the chat box. This is the open question and answer time. What we really wanted to do was bring you education, but also have the opportunity to hear from you. What are your questions, and ask them directly of Becky. So I don't see any coming in just yet, which is no problem. So I'm going to go ahead and get us warmed up with a couple that, oh, I do see one. Let me go ahead and take Rebecca Clark's. And if we have time, then I'll come to a couple that I thought of while she was talking. So Rebecca Clark, Becky asks, would you describe the applied HSR unit further? This is an intriguing and a great idea.
Absolutely. Basically, this unit, we've created now a memorandum of understanding. It's not great to have to keep going back to an email from a leader saying, yeah, we'll do that thing. But we ended up working with the chief of staff, which is our physician medical director of the organization, and knew that they were struggling with a host of performance issues. And they were having physicians basically during an access crisis doing qualitative interviews of other VAs that were top performers in the areas that they were really low performers on. And they had somebody who was, could work with data, but didn't know how to adjust for, age and gender and other kinds of issues in analyzing what were the drivers of poor performance. In fact, they didn't know how to pose that question. They just kept looking at their poor performance indicators and beating up primary care or something like that because they didn't know what else to do with performance metrics. So we basically came to them and said, well, what if we had somebody who's a PhD who costs you half as much as the physician? So the physician can go do primary care and in fact is trained in qualitative methods to do those interviews of best practices. And we have our PhD quantitative analyst who's superb at the data talking to you about the patient, the provider, and the organizational factors driving that poor performance indicator. And we could do that at half the cost. And that was not a difficult business case to make. And we didn't ask for a ton. And the physician's time was contributed because that's a VA-ism. and protected time. And that they connected to different service chiefs who were responsible for different performance measures and began that conversation. And in fact, this year the organization had less money than they were expecting to have, and we weren't sure if we were going to get funded. The service chiefs rose up, like torches, and said, don't take this away from us, because this is giving us evidence that we can do policy and practice action on, and we're not used to having that. So the reality is when people get used to having this, they don't want to lose it. So the issue is just building that business case at the beginning. And we're happy to share some of the initial documents. We did not make them read 10 pages of a proposal. We did it in big type on 2 pages with big bullets.
Wow, this is really great, Becky. And one of the things I'm super excited about is we're getting tons of questions coming in. So I'll go ahead and start fielding them to you. I'm going to field them to you in the order that they come in. So Ashley Ritter has a question, and she asked, as an early career researcher, it is a little difficult to take steps out of fellowship into embedded roles. Do you have advice on how to do this? What are key benchmarks for success?
So some of it depends upon what your, end game is. So I have fellows who are wanting to go into assistant professor roles. And so at universities, without doing any further embedded research, they can still publish on the work that they've done as an embedded fellow. But the publications may end up being more important than getting an operations funded grant. On the university side, getting even $1 million from the organization may mean less than getting $1 million from NIH. So some of these things are those challenges in academia versus embedded research. I would say the embedded roles, what I tend to do with my fellows is during their fellowship time, connect them to both traditional research grants and projects and some embedded work, so that they get experience managing and participating in both and writing papers and dealing with data from both. And that if they want to be hired as an embedded researcher thereafter, we begin to connect them to people and operations people and researchers in their areas of interest, so that we can start to generate the salary for them. So I don't have a bunch of FTEs. I don't have tenure track positions. I'm working on creating such for my PhDs, because my MDs come in and they get protected time and they get full-time jobs. I have to create that for my people. So I'm actually in the process right now of producing positions for 3 of my postdocs. And I've basically already identified the PIs as well as the operational leaders who would like to fund their time, basically. And once they're in, and they get working with the data and they start doing good work, and they start submitting their own grants, it takes a couple of years before they start being able to fund their own salaries pretty easily between grants and operations projects. Now, admittedly, I have people who get very addicted to operations funding, because you can write a paragraph or 2 and get $100,000. That's, but we have push pulls on some of those things as well. So, the key benchmarks for success, in all honesty, is ongoing coverage, right? Since I don't have permanent FTEs, I have been a non-permanent employee at the VA for 32 years. And so and you'll see over time, when we suddenly get an offer of a bolus of operations funding to do something, if I have people who are uncovered, it's not always, their lack of coverage is often a signal that they haven't figured out how to do embedded research, or maybe they haven't delivered in a timely way. So I don't tend to just make sure I cover whoever's left. We have to make sure that they in fact know how to partner. I mean, one of my last trials, I called it my 80 new best friends, at everyone at the provider level, the organizational level, and the national level, and having to keep them all happy. They're all very needy in their different ways. But that's its own skill. This does require a certain degree of emotional intelligence. I do have some folks who are better in a room with a computer, and that's okay. So we have to design the role for them that fits who they are as well. I hope that helps.
That was a great answer. Thank you. And it was really nice to hear kind of just the progression in your career, mentioning you've had a I can't remember what you called it, but for 30 years, right? So that's really awesome to hear in terms of, we know that the health services research field, in terms of the professions and jobs available is changing. So it's really good to get a glimpse into your career path. I'm going to go to Todd Staub, who has, I hope I pronounced your name right, who has a question. So the question that came in is, how do you keep the research agenda aligned with the clinical strategy of the VA system?
It's a great question, and I've got actually a pretty easy answer. The Health Services Research and Development Service that funds the intramural grants in VA basically points to whether or not you are doing work in an area of clinical and strategic priority to VA. We have a whole section we have to write about that. And they've just updated their RFPs, their general RFPs, and suicide, chronic pain and opioids, access to care, virtual care, those are some of their top priorities for the system. And so VA Health Services Research is saying, so what's our portfolio in those areas and how do we accelerate work? So they've just funded a series of consortia. We didn't talk about this, but I lead the VA Women's Health Research Network, which includes a 73 VA practice-based research network and several hundred VA researchers and clinician educators that we work together nationally to accelerate research in this particular area. So Health Services Research funded CORES, multi-center national consortia around those topical areas, all of which are partnered with operations leaders and policy leaders. So they fit together in that way. All the query funding, which is operations money, they just literally a couple of days ago surveyed all of the VA medical center directors and network directors and National Leadership Council members in central office as to their priorities. And then they just sent the top 5 to 7 out to us. And they're not things we often study. They're, employee retention, provider burnout, efficiency, some things that, we've had to get much more creative in how we bring together the right expertise to tackle them. But, our operations office have funds too. So, yeah, so that's how we do that.
That's fantastic. Thank you, Becky, for covering that. Rachel Meadows actually has a great question that came in a bit ago. Can you give an example of any experience you've had where institutional politics prevented action on your research findings or influenced the research you decide to conduct?
Good. There's never institutional politics. Okay, not. The prevented action. We did have in the harassment example, as things got heated and people were realizing that they had to do something, there were several medical center directors who said, I don't believe anyone's harassed in my VA. And I think the research is wrong. And that's never happened here. And some very high level people in VA central office said, this is a tarnish on VA's reputation, and they should be ashamed of themselves. And, this is going to keep women from coming to the VA. What ended up happening in that particular case is that a senior staffer who was a woman veteran to the House Veterans Affairs Committee was assaulted at the Washington, D.C. VA. And she was holding the legislation on harassment, quite literally. I mean, you can't make this stuff up. And so she wrote an op-ed in the New York Times, and the whole House Veterans Affairs Committee went up in arms. This is all in the media, so I'm not telling tales here. And it created so that created a hullabaloo and a lot of forceful action and words. And then the facility directors who were saying that it just could never happen there, some data gets collected locally. Oops, it's happening there too. And we had to demonstrate that this was across multiple VAs. We then expanded the data collection. But the bottom line is it's the importance of speaking truth to power and the importance of having strong research evidence that you can stand on. I've had other kinds of situations influence the research you decide to conduct. I've had people very anxious to do research in this space and other space when they think it's going to bring bad news. And I bring the same examples to them that I bring to you. There are times that I've brought forward, I have an early career person right now who is pushing up against some good news stories that the VA is putting out and demonstrating that there's some real hardships on the front lines among providers. And so what we've done is, because of those institutional politics, this is around the electronic health record and the $16 billion investment in that. We are working with other national program offices to create a forum for this early career investigator to report their kind of bad news stories. The strength of an embedded research system has been historically that even when you bring some difficult evidence to bear on important policies, if we can help those partners think about ways to act on that information, they always do better than they did without the information, right? If you explain to them the consequences of not addressing the evidence, they begin to embrace it further. So there's really not research I haven't conducted because somebody didn't want us to. I think the women's health example is a big one there. When we first thought that we wanted to do work in the women's health space, we went to the head of health services research and said, you know, this is what we want to do. What do you think? And he said, nah, there'll never be more than 2% of the users. We're never going to fund that. We were like, we're not going to listen to them. And we did it anyway. And the Women's Health Research Network's been funded for 10 years. So, and it's about to be funded for another 5. So it's, you know, when somebody says no, find out why they're saying no. And you're going to find a key factor in how you need to communicate what you want to do and why. So turn it into a win.
I really like that, how you're taking not just the opportunities, but turning the challenges around to become opportunities. And like you said in your presentation, win, win, win. Win, win, win. Yeah, 3 wins. Okay, so there's a question that came in from Denise Lilvis. I hope I got that right. Based on your examples, it sounds like embedded researchers need to be pretty savvy in terms of understanding media relations and perhaps even legal regulatory issues, because we're essentially uncovering deficiencies that make our employer look bad. How does an early career researcher develop these skills/awareness?
Great question. I have to say, I don't let any of my early career researchers go work with operations without a handhold, because they can fall down the rabbit hole pretty easily. I've had one fellow think that the operations partner was trying to steal her research ideas. It's like, yeah, trust me, not happening. We've not had legal and regulatory issues, chiefly because for our research, we have IRB and privacy and, you know, lots of approvals on lots of different levels. Even for our QI and evaluation work, we usually have privacy boards and other groups, ethics boards, just to make sure we haven't crossed any lines. And I can't say, even in all my years, I really have a good understanding of media relations per se. I would kill for that. I actually rely on Academy Health to advance training in that. They provide a wonderful half day or 3/4 of a day on the health policy orientation that I swear by. But I think that for an early career researcher, I would just make sure that you've got some links to some senior people, and also just develop your own relationships with some of these operations people. Some of the early career operations people can be really good partners too, because they've joined that organization to make a difference, and you are a master enabler in the best possible sense of the term for helping bring them along as they try and have impacts as well. I'll stop there.
Great. So we have another question from Megan Foradori. Do you have tips for approaching research that looks at providers' clinical judgment as an embedded researcher? This is often a source of pride for them, understandably, and we want to step carefully. What is being done or not done, in our case, is not evidence-based, but we think that others have intervened much historically because it will meet provider resistance, even at the research design phase.
So I want to see if I answer this correctly. It makes me think of, I teach in the executive MPH program at UCLA School of Public Health, and I have an eclectic mix of executive students, including surgeons on occasion, lots of other folks. And the surgeons that I've had historically have said, well, you can't measure my quality of care because I'm doing it right. And the quality of care is really based on what the team does or doesn't do right around me. That was an interesting conversation to have. So there are times when clinicians have blinders on in terms of their own quality of care, if this is what this is getting to. If you're talking about measuring quality of care as an embedded researcher in a healthcare system, the reality is you may need to bring along the physicians and other providers and leaders on, bring them along to the realities that there are standardized measures of quality of care that are validated and reliable, that there are established methods for assessing clinicians' judgment, quality, and outcomes. This is not just you, this is a whole field and body of work. And that there's a lot known about changing provider behavior and helping support physicians to do clinical practice guidelines, new protocols and procedures that in fact support them to do evidence-based practices that ultimately improve not only their performance, but their satisfaction in their job and their patient outcomes. So it's that kind of bringing them along, that you're not just saying you're bad and you're good, that you also do things in the aggregate. You're not, an IG, you're not an inspector general ferreting out a bad apple, but that this is a well-accepted nationally and internationally accepted set of tasks that people do to advance this work. You can see I've probably had to say this before. I hope that's helpful, but it's an argument you have to make it's not about the people, it's about the organization.
So Megan, did that fully cover the question that you had asked? I want to make sure that if there were any other comments.
That was great.
Perfect. Okay, so we'll go on to our next question from Elise Arsenal-Knudsen. Thank you so much for the presentation. This is very informative. That's what she said. I agree, Elise. I appreciate your work and sharing lessons learned. Is all of this work / research completed by MDs or PhDs, or do you have a model for RNs, PhD or DNP prepared? My experience is that nurses require different processes because of the nature of how employment is structured, especially at academic medical centers.
It's a great question. Yes, the work can be done by RNs. We tend to have PhD RNs conduct this work. I have less experience, admittedly, on the extent to which our DNPs have the methodologic training. I think that varies by program quite a bit. I think that most of this work is best done in multidisciplinary teams that include nursing, whether it's RN or PhD RN or not. And that said, I think it's still a challenge. The VA recently concluded their 15+ year commitment to a nursing research initiative where you only got funded if you were a PhD RN. And they were struggling with the quality of the applications and the quality of the mentorship. I think that's something we have to continue to solve. So I have some PhD RN and some DNP in process folks who are working to get the methodologic training they need to bring their clinical expertise and work experience to bear on these kinds of issues. Most of the RNs that I've worked with have been more on the QI side of the house. So part of what we're doing, even with that group I mentioned before, the Evaluation Decision Support Unit, is that these folks are, if they have academic appointments, they're more often in a clinical track, and we're trying to teach them how to write quality improvement papers. And I think that's an important model for our RNs as well. I have to say that some of the schools of nursing have been working to bump up their methodologic training, but it's just very variable at this time. So I think that the models are not as good as they need to be at this point. Yeah, and the other thing about the structure issue that you raise, I've been working for the last 7 years now to develop our nursing research program at RVA. And we finally got our organization, they hired a PhD RN to build the nursing research program. And we were offering to meet with and interview candidates for the FTEs that they were developing, which they welcomed because they want them to be health services researchers. But when we said, well, how much protected time are you going to give them to write their first grants? They went, protected time? And the notion was that they were going to be very busy seeing patients and designing QI programs and maybe evaluating something, but with no internal support to do any of those things, and no mentorship and no protected time to develop grants. So we realized they'll have a nursing research program with no research. So we're working on it, and we'll see how that goes. But it's a struggle. It's a struggle.
Well, thank you very much, Becky. It looks like we have